You're listening to MESO, the Mesothelioma podcast, where support, education, and outreach come together for families facing mesothelioma.
It says, no, it's on now. Okay, good.
Hi, guys. Thank you for being here today. And I am so grateful. I know for each and every one of you to be here. We have Eleanor Erickson. We call her Ellie. Lisa may pop in here in a few minutes. But as a special guest, we have Dr. Jeffrey Levada. Is that correct?
Levada, yeah.
Yeah. I'm sorry. Jeffrey, can you give me, well, we have a little bit of a background here. Did you want to read through that, Dave, or do you want him to say it?
No, just love you to give just a little bit of an intro on who you are and what you've done. Although we talked about it before, we just love to quickly talk about what you've done and how you got here.
Yeah, so thank you for having me on. And yeah, I'm Jeff Levada. I am a thoracic surgeon in the Kaiser Permanente Northern California system. But I also, have, kind of faculty positions at UCSF and the Kaiser Permanente School of Medicine. So I'm kind of a little bit everywhere, jack of all trades, I guess, a little bit. But in terms of mesothelioma, it's been an interest of mine since I left fellowship at the Brigham and Women's Hospital with David Sugarbaker in 2014. So so I guess for the last 12 years now, been running a kind of regionalized, centralized, high volume mesothelioma, multidisciplinary team, leading it from the surgical end, but obviously a multidisciplinary team with medical oncology, radiation oncology, and thoracic surgery, kind of just seeing all of the mesothelioma cases in Northern California. And then Kaiser's also in 9 other states. So we often do see a lot of referrals and a lot of virtual multidisciplinary tumor boards for mesothelioma, for example, in Colorado. I've operated on Washington, Oregon, Hawaii. So, and obviously Southern California as well. So kind of seen it from a lot of different areas other than just Northern California. So happy to be on and kind of share any of my experiences.
Oh, great. Thank you. So I wanted to apologize ahead of time because I know I have Lisa, Ellie, and Dave, who is very well versed in medical terms, but I'm not. So a lot of the questions or what I'm going to be asking is probably more layman's than anything else. So one of the things I did want to talk about, and Ellie had sent me some information about MARS 2. But before we get into MARS 2, I wanted to say, and only because, the clients or the patients that we talk to, we hear the different things that are going on as far as treatments that they're going through. So if you don't mind, I want to do this. So when I initially came on with mesothelioma, the EPP was a big thing, that if you qualified for it, great, you're going to have, even though it is a very, the recovery time is very, it's very heavy, I guess. I don't know if that's the right word to say.
It's a long road to hoe, that's
right,
for sure.
But, we know quite a few people that have survived EPP, right? And that was kind of a big thing at that time. And then I guess there was a paper written in 2024, MARS 2 2024, where they felt something different. They did a study on those, whether chemotherapy alone was the best thing for a client or chemotherapy followed by EPD. And the result of that was that they were kind of getting away from actually surgery, right? And so we would hear a lot of our clients say, yeah, they're looking more at quality of life. They don't want to put us through all that. And then in 2026, tell me what happened.
Got it. So that's great. You did a great job, a great synopsis. But what I would first say is in regards to the extrapleural pneumonectomy, meaning where you take out the lining of the lung with the mesothelioma, but also the lung, versus the EPD, which the MARS 2 looked at, extended pleurectomy decortication, where you save the lung sparing, and you just remove the lining. That the original MARS trial, so I guess you want to call it MARS 1 or MARS, that came out, over 10 years ago. The interesting part of that is that did show, again, that surgery, again, was not beneficial when it came to surgery versus, chemotherapy. But that study, the reason why a lot of us didn't necessarily go off of that either was because that was what you alluded to earlier, which was that was comparing extrapleural pneumonectomy, EPP. And we know that surgery, and we learned from that study that the surgery morbidity and mortality rates can be over 50%. Half the patients all develop complications. So not surprisingly, a lot of them didn't make it that long. But that, again, was based off of extrapleural pneumonectomy. So that led a lot of us after that study, even though extrapleural pneumonectomy is still done, even today. And today, a lot of surgeons still do extrapleural pneumonectomies, believe it or not. In fact, in Canada, it's fairly routine at some of these high volume places. But because of that, the majority of us, say 10, 12, 15 years ago, or a little bit even longer ago, have really kind of shied away from extrapleural pneumonectomies. And so one of the interesting things that I got to experience, and I know Lisa's on and Ellie's on, is that my time at the Brigham and Women's Hospital with Dr. Sugarbaker, before he moved to Houston, I was still there, and he was still there up until 2014, as well as I was his last kind of chief resident, was that we saw that transition. So half of my cases during 2012 to 2014 were extrapleural pneumonectomies, and we were doing hundreds. And Lisa and Ellie remember that. It was back the old days where just everything came to us, and 3 to 4 days a week we were doing mesothelioma surgery, and half of those were done extrapleural pneumonectomy. The other half were done extended pleurectomy decortication, or otherwise known as pleurectomy and decortication. But I saw that over that time period, even in that 2 years, is really fascinating, which is really why Dr. Sugarbaker is always kind of hard nosed and everything, but he even began to understand the some of the issues and the lesser comings of extrapleural pneumonectomy, where even during, I remember from 2012 to even later 2014, towards 2014 and 2014, we're almost always doing pleurectomy and decortication. So I really saw that differences. And I really saw how patients recovered from extrapleural pneumectomies, which was tough and terrible, even at the best center in the world, versus pleurectomy and decortication. They were generally flying by, getting through, and even the Brigham published more that they had good data with pleurectomy and decortication. So again, I saw that transition. So I guess we can pause there because I know it's being recorded or whatnot, but then I can go into the MARS 2 if you want to. But I just wanted to make that clear about the extrapleural.
No.
Yeah, go ahead.
Perfect.
Okay. So for MARS 2, the big difference is that MARS 2 now compares surgery, but with all of the surgeries were pleurectomy, decortication, and or extended pleurectomy and decortication, but not extrapleural pneumonectomy. And they were comparing that with chemo versus just chemo alone. And even with just pleurectomy and decortication, they, again, similar to MARS 1, but different type of surgery, they showed worsening survival in the surgery group, even though it was still a pleurectomy and decortication versus just the chemotherapy group. And so that's what Dr. Lim and colleagues in the United Kingdom published in 2024. However, fast forward to what you were talking about in 2026, I guess last month in July, we published out of the Society of Thoracic Surgery guidelines, a multidisciplinary group of 14 of us, thoracic surgeons, radiation oncologists, pathologists, and who am I forgetting? Radiation medical oncology, a statement that looked at all the data, not just MARS 2, but looked at all the data, and also was an expert panel of just kind of our own real world experiences that have been published, including the Brigham, including Memorial Sloan Kettering, wherever you want to, all the University of Chicago, all the big places. And we came together and looked at all the data in a systematic kind of review, formalized Delphi process, voting, all these different things and discussions, and over a year period. And we came up with a combination of taking in the MARS 2 trial, but with all the other data, with all the other experience, the real world data and everything, and combining that, and then coming up with our own kind of what we think of expert consensus document, they're called, or guideline recommendations that you can use for your, patients that a surgeon in wherever Omaha can use, or a surgeon in Japan can use, or even the UK can look at and go, well, this group of 14 considered what we rounded up international world experts of the highest kind of experience with mesothelioma over 30 to 40 years. And, we came up with kind of our recommendations that certainly we can go into, but definitely differed than what we've seen in the MARS 2 trial.
What was the shortcomings of the MARS 2 trial that were, the U.S. objected to? Some of our
so I have a list of 10 things, but we don't have time for that. So multiple people have different.
What the top three?
The top three. So the top three was one. The biggest issue was that a lot of us had was the trial design. We won't even get to the experience of the trial design. The trial design automatically required you to get chemotherapy first. Many of us in the United States don't even give chemotherapy first because there's been no trial. In fact, there was a recent trial, ERTC 1205, randomized controlled trial, that just showed that there was no benefit to giving it before and or after. It's the same. It's a dealer's choice. However, MARS 2, they, based on their, what they were doing in the UK and in Europe, they decided both treatment arms were going to get chemo first and then get surgery. But we know off of literature and data that only about 20 to 30% of all mesothelioma patients actually respond well to chemo. It is, generally speaking, don't respond that well to chemo. And we know these patients are already sickened because they have pleural effusions, or they tend to be older or not as sick. And then you weaken them more with chemo. And then you do a big surgery on them. Not surprisingly, already, they are going to do worse compared to just getting chemo. Right. And so what a lot of us said that we want to do, and in fact, David Waller has told this to Joel Dunning, and David Waller was one of the authors and one of the main surgeons in the MARS 2 trial, a prominent surgeon out of the UK, wants to do MARS 3. And ideally, MARS 3, or what many of us in the United States would have liked to see, a fair comparison would have been you either get surgery followed by whatever, chemotherapy, all your next mix up first. So you're the strongest. That's when you can handle it. And then you give the chemotherapy, or you just give the chemotherapy and see. And I think a lot of us, which is what we do, many of us do, is, often do surgery first, but we follow it up with chemotherapy. And that's what our guidelines really want. You need to get that systemic treatment in. But if you get the surgery in, first, how would those patients do versus just getting chemo? And a lot of us feel, and we've showed in, again, retrospective, so it's not a clinical trial. So it's, but we've showed multiple studies, Mount Sinai, MD Anderson, MSK, here at Kaiser, I'm forgetting some, in Japan, that again, retrospective, not perfect, but patients that got surgery and systemic therapy versus just chemotherapy alone, or even with immunotherapy alone, the group that got a multimodal approach with surgery and some type of systemic treatment lived much longer than the group that didn't. And unfortunately, we don't have a randomized controlled trial looking at kind of apples, what we consider apples and whatnot. So trial design was tough because a lot of those patients got weakened by chemotherapy and didn't have a good response. And right away, when you put them through a big operation after that, that already is an issue. That's number one. I know recorded, so it'll be like cut, right? Edit. So number two, kind of the issue was the extent of surgery complications was much higher. 30-day mortality, 30-day complication rate, and 90-day mortality were often 3 to 4 times higher than any other published big surgical literature with pleurectomy and decortication for mesothelioma. And for whatever reason, we don't really know, right? It's just, that's the data, right? But the mortality rates were 3 to 4 times higher. A 90-day mortality rate at 9%, meaning 1 in 10 of your patients were dead after surgery within 3 months. Okay, that is much higher than the other literature. Even within 30 days, their mortality rates of 3 to 5% were much higher with pleurectomy and decortication, where many of authors have showed that it's less than 1%. So already, if you have some of these patients dying off because of your surgical complications, your rate of survival will be lower because some more patients are dying earlier. Then you're not going to die right away from chemo. It's a slower death. We know that. It doesn't, and so the complication rates were really high. Now, not everybody knows why that is. One of the qualms that some of us have, number 3, was that the surgeons that were performing it considered high volume were usually only doing less than 10. Many of us have done, hundreds or whatnot, or, 10, way more than 10 to 20 a year. So we, in the expert group from the STS, felt that just volume and experience with mesothelioma was more important than anything.
Mm-hmm.
And so we felt that the experience level of the surgeons performing, nothing against those surgeons, but certainly were high, and those were considered high volume surgeons for the study, but were a lot less experienced, and that could have played a role in maybe some of the decision making and how to perform the surgery, and what type of surgery, and the complication rate. Number 3.5 also was, essentially that the type of surgery we're performing. That's the thing where it gets complicated with mesothelioma. That's why it's hard to say that you should never do surgery. That's why we don't agree with that. There's all these different kinds. Even you brought it up, Anna, extended pleurectomy and decortication. There's a regular pleurectomy and decortication. There's some people call it a radical parietal and visceral pleurectomy. There's all these different kinds, right? You could go in and remove some of it, a lot of it, all of it. You can remove parts of the ribs. You can remove all of the diaphragm, only part of the diaphragm. You can remove parts of the pericardium, all the pericardium. You can reconstruct with different types of mesh. And the more, generally speaking, the more extensive, the more you take out. In this case, the majority of their cases were removing all of the diaphragm and most of the pericardium. So where many of us in the United States, and this is where I learned from a lot of the other, surgeons, especially out of Mount Sinai, that they haven't, in 6 years, they haven't taken out the diaphragm. More than 80% were taking the diaphragm. We know that causes a lot of morbidity and mortality afterwards. And so it's not that those surgeons were wrong in the UK, but a lot of those surgeries were very, very big, aggressive surgeries. And it just makes sense, right? If you do better from surgery, or maybe it's done in a less aggressive way, but still get the same amount of cancer out and still get your macroscopic complete resection. Because we know with mesothelioma, you can't remove all the tumor. You remove everything that you see, but you can't get rid of it. And that's why you give chemo. So just get them through an operation to live another day, and they'll live longer and they'll have a better quality of life. And so again, a lot of those surgeries were a lot bigger surgeries and whatnot. So there's just so many nuances with this type of surgery that, I understand the data they found. The survival was worse, but I kind of gave you a lot of the reasons why the survival is probably worse. And can you extrapolate that for all of the patients here in different ages, and for a 30-year-old woman that has this? Can you extrapolate that and say that it's dogma to not offer surgery anymore because of MARS 2? And all we're saying is that it's certainly reasonable to go by MARS 2, and if you want, okay, don't have to offer it. But there's many of us that have experienced mesothelioma that think otherwise, and have good anecdotal and published data to show that that is not true, what we see with MARS 2, even though that was a randomized controlled trial, because of some of the issues that I talked about before.
At every IMEG meeting I've gone to since the one that was held in Boston, there's been this big fight, right, about MARS 2, and Sugar Baker's name's always brought into that. And even in Philadelphia this year, right, Friedberg got up and was, defending Sugar Baker's, legacy or whatever. But if you just think about what you just said, the 3.5 issues that you brought up, one probably contributed to 2. The mortality, right? The doing the chemo first probably did. So it's interesting. That was great information. Yeah. Thank you so much. It's the best explanation I've heard so far. I'm glad Waller or none of these guys are in the room that can start debating with you about it. So.
Well, that debate to be determined. I am debating, and I don't know if I ever told you guys, but you can welcome to publish it, because it'll be in Korea at World Conference Lung Cancer. We are debating whether or not surgery should be done. And so I'm debating that a role for surgery. And this is in September 12th in Korea, the World Lung Conference. Wow. But Eric Lim, as the lead author, is the con of surgery should not be done. And I'm running that session, so that's why I invited him, but I'm glad he accepted. So, so I'm putting myself.
The Brits get a little defensive, they get a little testy about it, right? So
Eric Lim, because he's actually given a talk. I mean, he's the expert in this, right? He did the trial, plus he's given millions of talks worldwide about this. And he is a purist. He is very much a randomized controlled trial is the way to go. And
Yeah.
I don't care what your experience is. This is a randomized controlled trial of this versus this. And it was randomized and blinded and nobody, and that's what the level 1 evidence is. So, it'll be interesting. You're right. I'm definitely not thinking it's going to be that I'm going to win and convincing. And I'm not trying to win, but we're making it fun by a pro-con debate. But he is when he speaks, and I've seen a couple of his talks, he can be very influential.
And convincing, yeah.
Convincing. That's an even better term.
Yeah. So, well, if they did do a MARS 3, you'd have to throw in immunotherapy too. So that'll make everything very complicated as well, right?
Exactly. That's the thing is that, a lot of the treatment, and I love randomized controlled trials, but as you know, from survival data and just setting it up and everything, when they set it up, it takes 10 years. So they set this up 10 years ago to run through. All that data is just with chemo and old school surgery, so the field's just too rapidly moving. And yeah, of course, it finally, it trialed out and you saw the results, but that was done in an era that we don't even do that type of surgery as much anymore. And we use, like you said, the immunotherapy is game changing. And it's just not relevant anymore. It's not apples to apples. So more because we know they're going to recur. We're not saying your patients that see you, or I'm not telling my patients that we're going to get rid of it forever and it's never coming back. We tell you you're going to live with it. It's something that you have to live with, and you will need other treatments, but you can live with it. And if you can have a decent quality of life, it's no longer a death sentence within a year or two. And that you can live longer with all of these new treatments. And, you saw there's more treatments that are coming down the pike that are not just immunotherapy, that are actually related and treat well with mesothelioma. And so, it's just, that's the whole, you brought up a great point, David, that they don't even take that into context, right? Because it was all done and trialed before immunotherapy came on. But when immunotherapy came on several years ago for mesothelioma, not just for lung cancer, but for actual mesothelioma, IPI and EVO, it was groundbreaking, right? So, yeah.
So, and I don't mean to dominate here, epithelioid versus sarcomatoid. Before immunotherapy, you didn't do much surgery on a sarcomatoid or biphasic, right? Now, are you doing surgeries, or you're still kind of just letting immunotherapy do its thing?
Actually, great point. But I would say before, that was one of the things that MARS 2, and so before immunotherapy and before MARS 2, I would say that one of the things we learned from MARS 2 and just what we learned anecdotally is that we were too aggressive. Many of us were too aggressive with biphasic and even sarcomatoid. Sarcomatoid was always classically considered non-operative because it comes back with so quickly and it's so aggressive, you die regardless. So most of us would say no, sarcomatoid, even before MARS 2 and after, right? But many of us were still doing biphasic. And in fact, the NCCN guidelines were talking, before MARS 2 had biphasic in there. Biphasic and or epithelioid. So I would say before MARS 2, we were much more aggressive about, epithelioid, sure, but if it's biphasic, we'll do it. But what MARS 2 taught us, and we definitely saw that, is the biphasics definitely did worse, and that was part of the problem. Right? They included the biphasics in there, and that was part of what was bringing the survival, shifts down, because that's just aggressive biology. They recur a lot quicker. Even if you take it out, they just kind of come back. And so what many of us learn now, and especially because you have IPI and EVO and the Checkmate trial showing that IPI and EVO does very, very well in patients that were considered unresectable, that especially for and had a pre-inkling for doing better with biphasic and sarcomatoid because they're more aggressive cancers. So the IPI and EVO attacks it better. That now I would say we are much less likely to operate on somebody with biphasic than epithelioid. Epithelioid, I think, yes, there's still a role for surgery. Biphasic, it's a little bit more nuanced, and more of us, because of some of the results that we saw in MARS 2, are becoming more selective. Because of that, those patients with biphasic don't do as well with surgery. And we've kind of always known that, but there was just nothing really to back that up until MARS 2. And then number 2, and now that we have a good alternative, like you were talking about, David, of IPI and EVO, the dual immunotherapy agents that do very well, and you can live longer versus just chemotherapy alone. With that for biphasic and sarcomatoid especially, that we tend to leave those patients alone now. And that's a big change. And in fact, it's such a big change, David, that the NCCN guidelines now no longer put biphasic. They no longer add biphasic in the indications for surgical evaluation. They just have epithelioid, plural epithelioid mesothelioma. Before, I remember, because when I used to give talks before, it used to not distinguish epithelioid only. And biphasic was even in there. And then now we don't see that anymore. The biphasic word is no longer a part of, oh, then if you have biphasic, go see a surgeon and then you can discuss. It just says plural epithelioid. So I do think that has been a little bit of a change. And so I do think, don't get me wrong, MARS 2 does offer a lot of benefits for what they did. They taught us to be more selective, and that maybe, being a cowboy surgeon of the old school days of like, hey, there's no other good treatments for mesothelioma other than just ripping everything out. Probably isn't real and relative anymore, and that we probably should be a little bit more selective, especially with newer drug agents coming along that can treat mesothelioma better than what we had in the past, which was really pretty much nothing.
Well, maybe we could do a follow-up podcast after you get back from Korea to see if you have a black eye from the.
Yeah, it won't be a black eye, but I'll be teary afterwards. Despite how strong I come out with these statements, the hardest part is you're going up against randomized controlled trial data, and us as scientists, us as doctors, even you as lay people, lawyers, nurses, not medical people. That's always what we've been trained on scientifically, and everything. That the level 1 evidence, the best evidence, is a randomized controlled trial that you can compare this group to this group, and there's no quote unquote biases of looking backwards.
Good.
Yeah.
What else did you want to ask?
No, I mean, that I basically wanted him to break that down. Makes it easier when I'm actually talking to people. A lot of times we'll ask the question, "Are you having surgery?" And I saw where it went from, "Yes, we are having surgery." No, they aren't having surgery, and now we're back at yes, but different. And which is good, because when we talk to these individuals, it's to know what you said, that if the doctor is a well-trained doctor and has worked with mesothelioma patients, I mean, they have the experience, right? You tend to want to send them over to whomever, which is what we used to do with Dr. Sugarbaker. It's like, we want to send them to someone that knows this cancer. And then it was, well, we're not doing surgery, we want quality of life. So you didn't really send them to anyone in particular. And now we're at, you do definitely want to go back to sending individuals to doctors that have the experience in this. And that helps me. Dave knows all this stuff, and it's just better to understand, where we are for each one of these patients.
So just a couple more questions. How much time do we have? Were we running out of time for him?
I have a quick question.
Okay, go ahead.
Oh, so can you just tell me, so I think you told us that you use a betadine wash, you don't do intraop heated chemo?
Right. That's another thing we learned too, right? And it was always dogma before heated chemo. But yeah, no, I do a betadine wash, and that's being trialed. Joe Freeberg kind of showed that in the past, but there is a clinical trial. I want to say either Dan Miller in Georgia or somebody's doing that, comparing it, doing their surgery with the betadine wash versus not with the betadine wash. So we'll see what those data are. But we know in the lab, actually, ironically from the UK, that mesothelioma cells specifically get killed by betadine in vitro.
Really?
It's always been shown. But whether or not it works in vivo, we don't know. But why not? If it kills it specifically, and it's not going to hurt you, why not? And so I do a betadine heated bath, and obviously the more you heat it, right, similar to heated chemo, the higher kill rate it'll have on cancer cells, because heat bursts cells, right? And so the reason why I didn't do heated chemo, stopped doing heated chemo, and that's why you need to be at a big center to see. I saw a lot of the brutalness of heated chemo. I was the one. Fellows are the one doing the heated chemo. Not only does it add another hour to 2 hours in the surgery, they drastically get more renal failure. They drastically stay in the ICU longer. They have way more fluid. You know this. You guys know this. But that was just like, oh, well, that's what we came up with, and we do it because in theory, but it's never been shown in research studies to show that it is or in a randomized trial that it's superior to doing nothing at all, other than meaning doing surgery versus surgery with high talk. The heated chemo, there's been no study to show that it's beneficial. However, 2 years ago, the Brigham our very own the Brigham did publish data showing that patients that had high tox or had the heated chemo had way longer, double the length of stay, not surprisingly, and double the length of acute renal failure. So, and those are really important things that I care about. That's what will kill you at 90 days if you have renal failure, because, although, those things. And so I didn't wait for that study because it just came out 2 years ago. Right when I came out of practice out of the Brigham, I knew that I wasn't right. And that's what you learn. You take what you can. You don't take everything. You don't say, I'm just going to be a sugar baker clone and do exactly what he does, because you learn from what he does and what are some of the stuff that maybe he didn't do. And one of the main things that I saw that was just not worth it at all, not worth the bang for the buck, and getting a perfusionist in and all this time the surgeon is sitting there. We were just sitting there waiting for the chemo to just get all toxic in our face and not really help. And the patient has complications, whatever, that I was like, no, I don't think it's going to be beneficial. And sure enough, the Brigham finally published, because it takes 10 years to look at their whole data, published that heated chemo didn't, even though they have some papers, of course, that are for it, and they still do that. But that paper really, really emphasized that the complication rate's just really too high and doesn't help improve recurrence-free survival. So yes, you're right. I never, since I've been out since 2014, I've never used heated chemo, but there's certainly people that use it, and we're not against it. But one of the things, Lisa, that I'm glad you brought that up is in our consensus statement, one of the PICO statements, or one of the actual statements, is what is the role of, we call them intraoperative adjuvant therapy, because there's other people. Joe Freeberg looked at photodynamic therapy. Do you burn in there? Other people have looked at, obviously the heated chemo and all this, and we looked at all the data, and sure enough, none of the data supported the overall that you should, or that we even recommend using heated chemo. In fact, we said there is not clear evidence of using anything in the operating room other than surgery. We didn't say Betadine, we say anything. We said none of that data is out there, but we reviewed it all, but none of the data was convincing enough or high level enough for us to recommend that you should use heated chemo or Betadine or anything. We just said it is up to the surgeon, essentially. It was basically level C evidence. So we don't condone it per se. There's nothing to say that it was just super terrible, except for that one paper, but other papers didn't have some of those complications. So we just said there's no proven benefit, and it's a dealer's choice.
Is that true of both pleural and peritoneal, or would you say primarily?
Just plural. Yeah, peritoneal, a little different. There's a little bit stronger evidence for HIPEC, heated pleural for peritoneal mesothelioma. So no, this was just for pleural when we evaluated the intra-op heated chemo, just for pleural, showing that the data wasn't great.
Well, I wanted to ask 2 more questions, but I hope this is the last time we get you on it, because you've shared some information that truly I think is very important to us and our, because we're like you, right? We don't get every individual in the world that has meso, but we talk to dozens of them every week, right, at different stages of their lives. So this is really, really good information. But okay, so what about like a heated immunotherapy type regimen? Anybody have done anything like that yet? I mean, and it may not make sense. That may be stupid, but what do you think?
No, not stupid at all. I think that's the next kind of level, is doing so. I don't think it's or vaccine. People are looking at vaccines. Injecting that in right now, right? Injecting a vaccine to imbue the immune response that'll attack just mesothelioma cells. Same thing with doing localized immunotherapy. I think that would be fine, because it would be slightly less renal failure. The only issue with immunotherapy, for example, is we know it's got a lot of lung toxicity. You do keep the lung, but then you add immunotherapy to it. You may have, we don't know this, and nobody's done this yet, but in theory, you can have a little bit more lung inflammation, otherwise known as pneumonitis. But I do agree with you, David. Something in addition to in our surgery, because I remove it all, but we know that they're circulating around this, because it's just like it's plaster everywhere. I do think something more targeted, where we could, do a spray. In fact, there is the group at Stanford, it does have a chemo spray. It's just the regular chemo, but it's a spray that they do, that they spray on it. And they're trialing that right now. They just did the first one. So doing chemo spray, but ideally, but this is just the normal chemo, right? Ideally, and that can cause, renal failure and all that stuff. And it's just chemo, not directed just for mesothelioma, just regular chemo. But what about, something targeted more towards mesothelioma, something local, something additional? Because radiation clearly with the data hasn't shown as a routine should be improves your survival. And that's the idea of why people use why we used to use radiation, or sometimes I will use radiation, is because we know we couldn't get it all out with surgery. We tried everything that we saw, but let's radiate all around that area. But the problem is that a lot of the toxicity with that is still brutal, even with new techniques. So ideally, I would love to have a betadine bath that's specific to meso, not necessarily betadine, but something mesochemical that it takes 5 minutes, just throw it in there, circulate it up, and have it be killing mesothelioma cells, suck it all out, and that's great. And that's, that would, I think, be very beneficial.
Any other therapies on the horizons you'd like to, you think are exciting?
Yeah, so the PARP, the PARP inhibitors, so there are certain molecules or genes and proteins that are specific just for mesothelioma that are even different than lung cancer per se. And there are certain drugs that they're trialing in phase 1 studies. So other drugs other than immunotherapy, other than vaccine trials, other than CAR T-cell trials that are just looking at inhibiting mesothelioma cancer cells on a protein level. Whether it be injectable or vaccine or pill therapy, those I think would be ideal. Something more personalized and targeted. Right now, if you think about it, we still only have surgery, radiation, just overall chemo, cisplatin and pemetrexed, and just regular overall immunotherapy, meaning IPI and EVO. But again, remember, immunotherapy is not specific for just meso. We use it for all different kind of cancers. So I think we still, in the on the horizon, are the ones, what I'm interested in are the ones that are going to be targeting more mesothelioma, because mesothelioma, as we know, is a different beast than lung cancer. It's a different beast than melanoma. It's more aggressive than renal cell cancer. All those ones that respond well to immunotherapy. Yes, it responds decently well to immunotherapy, but nowhere near what the response rates are for lung and kidney and all those other ones where it's dramatic, the immunotherapy. Even with the mesothelioma, it's not dramatic. I mean, it helps better than chemo, but it's not dramatic enough. They still die, they live 4 months longer, right? And with the IPI. And so I do think we need more targeted approaches. And even some of the immunotherapy approaches that are coming out now. And I think that they were doing it at Baylor, and I guess Taylor and then we're, I guess, going to bring it over to Vanderbilt, but they were looking at more novel immunotherapy agents. Again, still immunotherapy, not directly at mesothelioma, but they were newer age and maybe thought to be better at controlling more aggressive cancers like mesothelioma. So I think that is great. And then lastly, I'm not opposed to doing systemic treatment before my surgery. Okay. But I'm opposed when it's chemo, when it's not going to really help. And it's not going to help my surgery, and it's going to make the patient weaker. But there are some new trials, and again, Taylor's looking at this. Ripley is looking at this with giving novel immunotherapy before, and then doing surgery. But they're having trouble accruing because, like you said, nobody wants surgery anymore. And so how are you going to even get them in to do a trial? So they haven't been accruing. So I don't know if that'll ever pan out. But if we were ever able to show an effective immunotherapy that's not that toxic, because it's immunotherapy less toxic than chemo, and it works and it shrinks things down, I'm all for it. It's not that I'm anti, this neoadjuvant approach, because I'm all for it. It's just we haven't seen that yet. And until we really see that, I'm not convinced that you give stuff before rather than just what we do now is like, hey, it's bad right now, they have pleural effusions, they have pain, they look sick, you see them, they look sick, right? You got to get this stuff out versus like, oh, let's keep it all in and then make them sicker with chemo and hope that it shuts things down when we know it doesn't. And most of those patients won't make it to surgery. And even the ones that they probably did take to surgery, we don't know. This is the bias of a randomized control trial on the MARS too. How healthy really were they? Right? Right? How healthy were they? They didn't include the ones where they didn't operate on, right? That got chemo, that were supposed to get surgery, but didn't get surgery, right? They only included the ones that got surgery. And again, how were all of them super healthy and young and everything? And we know that they weren't. So anyways.
Can I just ask one question? Congratulations on your consensus article. That was really great. What's been the reaction to it?
So far, really, really good. But that's just in the thoracic surgery community. Very happy. Everybody's like, yeah, we knew that kind of, or at least in the United States, the big, they're like, okay, yeah, we knew that. I just heard from Raja Flores the other day, he's like, of course, right. That's just what they do. And Andrea Wolf was on our, his disciple was on, and you guys know Andrea, where it was on our
Yeah.
consensus statement. But again, it's kind of like known. So nobody's like, oh my God, this is like the United States surgeons. What I don't know, Ellie, and that's why I want to bring it to the world is, what do the other people think around the world, the surgeons? Yeah. And more importantly, what I need to know, and that's why I need to talk about it in ASCO and the medical oncologists. What do the medical oncologists think? Because if I can't change the minds of the medical oncologists, because they're always going to see MESO, right? If I can't change the medical oncologists of the United States, because they're all bought into Mars too, then we're not really doing a great thing. We're not, but they're not aware of this yet. Ellie, and that's why I'm so keen on trying to get it out there to more people, because if patients hear about it in your whatever, then they can go back to their medical oncologist and be like, hey, have you seen this? Because I guarantee you they have not, because it's only circulated with surgeons. That's the one bad thing about these cool things, or STS and all this, but they're so, I mean, it's not like medical oncologists read our top cardiothoracic journal. Just like I don't read JCO, their top on medical oncology, because it's usually stuff that I never need to see. And if something does come up that's cool, that's relatable to me, I don't really know about it or hear about it, but it's probably like a year later. And that's why I need to combine that a little bit better, Ellie.
Yeah. Oh, well, it was great.
Thank you.
Yeah, fantastic.
Yeah.
Good, because you guys don't have anything, but I did want to add, this is really good because Ellie and Lisa are on. I think they understand this more than others, that you guys have to know, that I wanted to bring up, which is which is a problem that I'm really worried about with mesothelioma surgery, even in the United States. We already know Europe, and for most of Asia and like around the world, they're not doing this surgery. One, they never really believed in it, and two, they just don't have the experience of doing it because they never really believed in it. Is that in the United States, we're losing all of our experienced mesothelioma surgeons. They've either passed away or they're retired, like Val Rush. Losing Val Rush, obviously she's great and healthy, but she's retired. She no longer does the surgery. She no longer has an office at Memorial Sloan Kettering. Right? Joe Freeberg is still around, but these people are in their 60s. And Bob Cameron, one of the pioneers of pleurectomy and decortication, he is officially retired. Okay. So we don't have that experience in those people. Harvey Pass is great, but he doesn't really operate anymore, I don't think, right? And so these are all the people. Even Bueno still operates, but I can tell you, Bueno's not gonna be around, he's not gonna do this forever. I mean, how old is he? So we're losing not only the people that are like 5,000 times crazier than me, they have 5,000 more clout than me. So people are always going to listen to what they say, right? They're not going to necessarily listen to me yet, right? And so we lose that influence. And then not only do we lose those people that are really believe in the surgery and that have the most experience in the surgery, because they've been gone for so long or whatnot, we've lost the whole new generation of training surgeons. And especially in the robotic area, where most surgeons don't feel even comfortable doing an open operation. Most robotic surgeons don't know how to do an open operation anymore. And so they didn't train on the air anymore. And mesothelioma is the last of the classic open operations. Whether you do pleurectomy, whatever you do, it's still open. And that we don't have any, the older surgeons no longer operating on anymore, or they don't have the stamina to do it anymore, or whatever, they believe in it. The younger people are even worse. They don't even know. And even if your medical oncologist or your patient gets referred at a major academic institution, which is where they think it's going to be best, those surgeons probably won't even offer the surgery because they don't feel comfortable doing the surgery, even though they're at an MD Anderson or City of Hope, even UCLA. Brian Burt, I love Brian Burt, but I don't even think he does much meso anymore. They don't, it's sad, right? But it's because he's into the robot and he's into other cool stuff. And I get it. Brian Burt loves AI and he's a great friend of mine, but we lose all of that. And so I'm kind of that generation X where it's in the middle, where I see both sides of it, the robotic age and the kind of old school age. And I feel like it's a good compromise for mesothelioma surgery. But I would say there's a lot less of us. I mean, me, Taylor, Sean Groth maybe, but again, these are just Sugar Baker disciples, right? There's not many of those left. And even the Sugar Baker disciples, Andrew Wolf was there's only a handful of us left. And we're only smattered across the country, that even if you did send to a surgeon right now, David, Anna, who are you going to send to?
Yeah. Good point.
Tell me, name 10 surgeons that that do this surgery well. Name 5.
You.
Well, yeah, you guys are biased because I'm on, but okay. I think that's the problem.
No, you're right.
About.
Raja Flores and Andrea, they're all,
Is Jacques Fontaine doing any surgery now or no? Is he
He's
administrative?
the guy that, again, another Sugar Baker disciple that I referred to. Yes.
Does Alex
Marcelo De Silva down in Florida. He
Yeah.
still wants to do it. He's still
Marcelo's in Texas now.
Is he?
Yeah, I think he's at UT. Yeah, he's moved here.
That was recent because I just saw it.
very recent.
Marcelo?
And
De
he was
Silva?
yeah.
Not
Who
De
is
Silva, Marcelo. I'm sorry. Louis.
Lewis.
Lewis. Yeah, Lewis.
You know him, Jeff.
Green. Marcella Green. I'm sorry. That's what I was talking about.
Oh no, yeah. Marcelo De Silva's still in Orlando.
Yeah.
And
I'm sorry. I didn't mean.
Farabad doing it in Seattle?
What's that?
Is Alex Farabad doing it in Seattle or no?
He doesn't, but there's another guy that took over for Eric Valier.
Yes.
Retired, and so there's a younger dude down there that he gives him to.
Okay.
But Alex got really into the robot, so I don't think he does much of it. So there's one person up in Seattle at Swedish, I want to say, or whatever.
Yes.
Where Eric Valier
Swedish,
was. Yeah. Nobody really in Oregon that much. I do it. Me and Leah Backus do it up here. UCSF doesn't do it. UC Davis doesn't do it. Down south, it's pretty rare. Cameron now refers to this new guy who, again, I don't think he does much meso because he's brand new and I've never heard of him. But he seems like a nice guy, Vignesh Raman at UCLA. So they don't refer to Brian Burt anymore. If you go for meso down there, Cameron says go to Vignesh Raman, but not to Brian Burt, who's the chief there, and he still doesn't refer to him, and not to Jay Lee. Jay Lee is another guy that can do it. But again, Jay's into his other stuff. Now Jay runs a company. He's into people get into other stuff because meso, I mean, it's a morbid disease, right? I mean, we know it's not fun taking care of them. And we all know that, right? And so of course, if you go to something sexy and whatever, in medicine, and where the patients will live and not die within a year, right? And that's really what's happening. And the new people, they don't know. When they look at these big surgeries, like the new attendings or whatever, they're scared of this. Or they're like, oh my God, what you guys are doing is malpractice because you're just ripping, because it's old school. So, and that's not the way surgery is taught anymore. It's very delicate. It's like you use a robot, take less out. So mesothelioma is kind of against what we're moving towards, which is do less. Do less. But with meso, it's still an aggressive disease. It's all over the place. But man, have I seen and that's the problem. All these younger surgeons are anti-meso surgery. And that's what's hard for me. I got to go up against all that. They have no experience at all, and they have no wherewithal, and they don't have experience, but they can go by the guidelines, or they can go by Mars 2. They can quote Mars 2 any day and try to go up against you. Right. And that's what they do. And so there are a lot of surgeons that don't want to deal with that. Right. Yeah. Why would you deal with a high-risk surgery for a patient that's probably sick as a dog already, old vet, whatever, that doesn't care regardless, right? I'm just kidding, but it's true, right? It's not like
especially if you rarely see it too, right?
Right. And so why would you put yourself up against malpractice and people saying this or all that? Because that's what happens in meso. And so I've been lucky enough, like knock on wood, but I will tell you, there are a lot of haters out there. In fact, out of the 14 thoracics, out of the 14 thoracic surgeons that I work with, none of them will do the surgery. I'm the only one.
Wow.
So you can see what an island's like. An island truly.
Yeah, right. It really is.
Yeah.
Interesting. Well, this is the best podcast we've had.
I'm telling you.
We better cut that out or I'm going to get in trouble. But that personally is the best one we've had. Thank you so much for
very informative.
It was great.
Yeah, you're welcome. I'm always happy to share, and I'm hoping to get things out. So I hear back from your patients, or not necessarily for me to do surgery with me, but just I like to hear what other people are saying, because I don't know what they're saying in Nebraska or Texas. I don't know what Taylor's doing. I mean, Taylor and I talk, but I'm not going to call him up right now and be like, hey, whatever, because we're just busy. But I'm always interested in what people around the country are doing, because I remember what it used to be like, and now I know what it's like now, which is what I assume, that nobody's getting anything done surgically. But I could be wrong. And so I'm always curious to, hear more from you all.
That would be fascinating. The numbers, how many surgeries are actually being performed now. That would really be interesting.
Yeah, that would be interesting.
I know. I got to look at that. There's a way to look at it to see the numbers, but through the SDS database. But you're right.
You need to have a fellow look it up and then publish it at the next IMEG or something, right? Or ASCO or something.
Yeah.
Absolutely. To see the trend.
Drop of,
Yeah.
Like, we're saying that because it's anecdotally, but I don't know what the actual numbers are dropping. You know, I'm sure they are because that's what I think, but you're right. I haven't published that.
Right.
So you're right. That would be interesting to really see and to see maybe after 2026, do they start picking up again or not? I don't know.
Right, right. Maybe if they,
You never know.
Well, we better let you go, but
Yeah,
thank you so much for joining us.
Thank
And
you.
we hope we can
Thank you very
talk
much.
you into coming
Good to-
back and doing it again later.
yeah, good to see you.
Yeah, podcast.
Good to-
It's great to see you, Elliot and Lisa. So
Hi,
thanks for
Jeff.
having me on.
Thank you.
Take care.
Okay.
All right.
Bye.
Have a
Thanks,
great day.
guys.
Bye.
Bye. Bye-bye.
Thank you. End recording up on. There you go.
Okay, what do I do? Get me out. Okay, studio.
Ellie's like, let me out.
How do I get out?
Thank you for listening to MESO, the Mesothelioma podcast. For more information, resources, and support, visit our sponsors Danziger and De Llano at dandel.com.